So, the topic that I have is painful neuropathy. What are the therapeutic options we have available today? What exactly is painful neuropathy? This is the presence of the symptoms and the signs of peripheral nerve dysfunction in patients with diabetes after exclusion of the other causes. So this is usually when we diagnose it, it is something which is one of the last things that we think of. On the other hand, it should not be that way. So basically, what do you define it as? You define it as the clinically diverse disorders because it can affect any part of the nervous system with different anatomical features and clinical causes. Each patient is different and the phenotypes are also different. Besides this, there is a common underlying pathophysiology in the consequence of hyperglycemia and microangiopathy, which is also associated with it. The commonest, of course, that we see in our clinics is distal symmetrical sensory motor neuropathy. This is usually what the patient comes with. I'm sure at some point of time we have all seen patients who come to us with different kind of description of pain, whether it is tingling, numbness, burning pain, any other kind of pricking pain, shooting pain, various descriptions are there. And this is a huge healthcare burden, and however the treatment options are very limited, of course prevention is the key. So epidemiological, it shows that if there are so many diabetics, at the time of diagnosis, even 8% of the type 2 diabetics have neuropathy already. The latest St. Louis Valley cohort showed a prevalence of 25.8% in patients with type 2 diabetes and 11.2% in patients with IGT. So at any point of time in type 1 patients, there's about 34% of neuropathy, whereas 26% had even painful neuropathy. However, it is, like I said, the presentation is heterogeneous and there is different patient population. Also, the definition of neuropathy is very difficult to ascertain because every study has a different definition, and the methods of assessment are also very varied. Now, what are the different types of neuropathy? Like I said, symmetric polyneuropathy, the most common being the distal polyneuropathy. There are different variations, some which are acute and severe, some which are not so severe. Then we have the autonomic neuropathy. Besides that, we have the asymmetrical focal and multifocal diabetic neuropathies, which could be lumbosacral, could be radiculoplexipathy, and truncal neuropathies. Then there are cranioneuropathies, then there are limb microneuropathies also. And there are some which are episodic, some which occur with hyperglycemia, and some would be treatment reduced. Like sometimes if a patient has very severe hyperglycemia and you control the blood sugar very rapidly, they come back to you saying that, okay, my blood sugar is very controlled, but now my pain, the pain in my legs is very severe and I'm not able to sleep at night. There are varied pathologies. They are mostly all hypothesis, metabolic, which could be because of the production of destructive metabolic products, the activation of the aldosterone reductase pathway, the protein glycation with the glycosylation of the nerve tissue structured proteins, the vascular theory wherein the glucose is deposited in the basement membrane. This decreases the permeability and builds up the toxic metabolites. The microvascular ischemic theory, the thickening of vessel walls, endothelial hypertrophy leading to ischemia. So the pathogenesis is varied. It's very difficult to say what is the exact pathogenesis in a specific patient. Like I said, it could be vascular, it could be metabolic, and different kinds of variability is there. Now the patient, these are the kind of patients that we see day in and day out. Like I said, they come with varied symptoms. They could have numbness, they could have tingling, burning pain. Usually the burning pain is what brings the patient to the doctor. They usually land up either with the family physician or they come to a diabetologist, endocrinologist, and sometimes it may not even be that the patient is diagnosed to be diabetic. A lot of times they even go to a neurologist saying that I have burning in my feet. What do? I am not able to sleep at night. Now, the worst is that this pain occurs in the night, it occurs at rest, and it doesn't allow the person to sleep, thereby reducing their functionality, because if they're not able to sleep, then in the morning they're not able to work and other things. There is a glove and stocking pattern, and there is an impairment in the joint position sensation. Many a times these patients are detected by the neurologist. They send them to have their blood sugars done and find that they are diabetic. Sometimes it also can be missed, and most people think that it could be some other cause. These days a lot of people have these burning pains, and first thing that is done is vitamin B12. Once the B12 levels are corrected, then they feel that okay, this was the cause and maybe this is the treatment. Besides that, sometimes they have distal weakness, there's mild or absent reflexes, there's some amount of foot muscle atrophy. It is not very disabling. A lot of times they will tell you that they walked and they don't realize that their slipper fell off, or where did they lose their slippers. A lot of times this muscle pain is not proximal. So it doesn't actually impair their day-to-day walking and other functions. The tendon reflexes are also reduced. Now, is it diabetic neuropathy? Besides that, we also have to exclude the other causes. Mostly it could be nutritional deficiency, like I said, B12 deficiency, it could be paraneoplastic, it could be some toxic. A lot of times there are people who have a lot of alcohol, so it could be due to that. Besides that, there could be some infection, hypothyroidism, uremia. So these are the causes that we need to exclude. The diagnosis could be made on the bedside by checking with the pin or light touch, vibration sensation, proprioception, perception could be done at the clinical bedside. Various methods are there, right from using a pin, a wisp of cotton, tuning fork, reflex hammer. The other method, which is semi-standardized, is the nylon monofilament perception. This should ideally be done every time, at least once in a year for every patient. And other tests which are there are the screening test, which is the Michigan Neuropathy Screening Test, which is usually a questionnaire which is given to the patient, and then to evaluate what is the status of their complaints, and thereafter they are evaluated. There are several other assessment tools which are made for the diagnosis. Now, what are the other tests which are done? Most of the times these patients are not evaluated properly. Sometimes they even are evaluated and there may not be actually some test which is positive. The nerve conduction tests are advised, but a lot of times they don't do it, and most of the time we don't even advise them to do nerve conduction tests. Besides, nerve conduction test is done, it shows a mild conduction slowing in the NCV and the F-wave proportional loss to the axial loss. EMG is also done to evaluate what is the status of the nerves. Besides that, sometimes they could be even normal. The EMG NCV could be even normal. There are several other testing like the quantitative sensory testing, the density analysis, skin biopsy. Now the newer testings which are still in the pipeline is the corneal confocal microscopy and the optical coherence tomogram, because they realize that these also are very fine nerves and they can at least be evaluated. Of course, it still has to come translated into clinical practice. But usually the clinical judgment of the physician is far more important to diagnose the diabetic neuropathy. The intraepidermal nerve density in the skin biopsy can be evaluated, and as you can see the different kind of pictures that how the density is lost in a diabetic neuropathy. Ideally, every patient that we see should be diagnosed at the time of should be screened for neuropathy at the time of diagnosis and every year thereafter. Patients who have type 1 should be screened 5 years after diagnosis, and thereafter every year they should be screened. Another group which is very significant is the pre-diabetic. What do we do to a patient who comes with a blood sugar of 105, 110? Those are the patients who also must be screened, because it has been found that even these patients have about 11% of these patients also have neuropathy. And if it has been detected, if we are able to pick up something, we can advise them what the blood sugar control is, we can advise them further treatment. But if we miss it at this stage, it could be missed for a very long time until they appear with symptoms, which sometimes could be much, much later. Now the management, I divided into 4 components. So first is the part in which we try to slow the progression of the disease. Besides that is the relieving of the pain, managing of the complications and restoring function, and the nerve repair and growth. So the first thing that is very important is the slowing the progression. The best way to slow the progression is to see that they are able to maintain their blood sugar levels within normal limits. If the patient is a diabetic under the age of 60, their blood sugar levels should be in the range of 80 to 120. That is able to delay the progression of diabetic neuropathy. Older than 60 years, the blood sugar should be between 100 and 140 milligram percent. Blood pressure also must be well controlled. The lipid control is very essential. A lot of the times we do not even do their lipid profile. Once a year, if the lipid profile is done, we are able to detect, especially if they have elevated triglyceride levels, they can be put on a proper diet and exercise plan. They should have a proper healthy eating plan and an exercise plan which is able to improve their circulation. They should maintain a healthy weight. Normally, a lot of these type 2 diabetics are obese, and they are unable to even feel their toes or their other extremities. If they are smokers, they should be asked to stop smoking and avoid alcohol. Now, the management of management of blood sugar levels. In the DCCT trial, we saw that in the intensive arm, the HbA1c was maintained at 7.4%, and in the conventional group, it was about 9.1%. This was able to reduce by 64% the level of complications. And this was very significant. Thereafter, all the patients have been advised to see to it that their blood sugars are tightly controlled. However, the ACCORD study showed a significant reduction in the loss of sensation, in the sensation to light touch, which was one of the 4 neuropathy indicators. And however, the intensive arm which showed that there was an increase in the mortality. So it is very careful. So that's why we need to individualize the targets for every patient. It's not necessary that every patient has to have very, very low blood sugars, but as per each individual, the targets can be prepared. Now, how do we relieve the pain? Because when we as clinicians see these patients who come to us crying with pain, yes, a lot of them come crying with pain. Of course, sometimes I even tell them, I said, it's okay if you have pain, that is a good sign, because if you don't have numbness, that is even more scary. When you have numbness in a foot, it is really very scary, because you don't know what the sensations are, you don't know how you will get injured, and you don't know how you will even have a wound and probably land up with a loss of limb. So relieving the pain is very important. There are a lot of people who come that in the night that they cannot sleep. They said that even if we are able to sleep, but once we turn, the bed sheet touches the foot, and we wake up because the pain is so painful. Similarly, even while wearing their clothes, the sari or the pajama or whatever they are wearing, if it even touches the toes, they complain of pain. So this is an indigenous way of trying to keep it in such a way so that they are not able to touch anything. And simple anti-inflammatory agents or analgesics can be given symptomatically. However, we have to be careful when we start them with NSAIDs, because usually they continue to take it for over a long period of time, saying that, you know, this is what brings me pain relief, so I want to take it. Normally, the first choice for the pain relief would be anywhere between tricyclical agents, SNRIs, that's serotonin, norepinephrine, reuptake inhibitors, or GABA analogs. The second line would be the opioids or topical treatments. So these are the different sites where they act. Most of them act either at the brain level or the spinal cord, and the skin, the capsaicin is what is the local treatment available. The tri-anticyclical depressants, these are what we have been using for a long time. Though they are not really indicated. As per the studies, none of them really say that these are the medication that you would give a patient with painful neuropathy. But they affect the sodium channels and the N-methyl-D aspartate receptors. Thereby, they block the serotonin and the noradrenaline reuptake from the synaptic clefts, and there is varying degree of anticholinergic receptor inhibition. This is, however, giving these medications sometimes could be quite non-effective or probably quite difficult, because a lot of times the patient comes back with the complaints that, you know, they have had either they are sleeping too much, or sometimes a lot of people it doesn't even work. Besides that, we have the other effects, that the dryness of mouth, blurring of vision, postural hypotension, because sometimes if they want to wake up in the night, they land up feeling giddy and even fall down. So those are the things that we have to educate them about. So this is usually associated with a high burden of side effects. So therefore, the use for this should be limited. However, an amitriptyline, which we most commonly were using earlier, is actually the least safest of the agents. Now, SSRIs, these are a little less effective, but they are the first class of drugs which was approved for diabetic peripheral neuropathy in 2004. There were studies which studied duloxetine at 60 mg and 120 mg, and they reported significant improvements in the average pain scores. Besides this, the Cochrane collaboration also, which did a comprehensive review of 8 studies which had about 2,700 participants, concluded that they were very effective in the management. The side effects in comparison were minor. Constipation and somnolence, these are the two side effects, adverse effects which the patient come back with, and usually it can be very painful, or it could be very difficult, because sometimes if they are you know, still very drowsy, very sleepy, then their working gets impaired. Then besides this, there is another SNRI, that's venlafaxine. This increases the synaptin serotonin, and this is useful as an add-on with gabapentin also. It is relatively well tolerated. Of course, in some patients, the side effect of nausea and somnolence is there. Gabapentin is what is most commonly used these days. The mechanism of action is the inhibition of the alpha-2 delta subunit of the presynaptic voltage-dependent calcium channel, and this mimics the action of the neurotransmitter GABA. This also increases the levels of GABA in the CNS, and there have been many reviews to see that there is a balance between the safety and the efficacy. Like I said, then is, okay. So this has a higher potency as compared, pregabalin has a higher potency as compared to gabapentin, and this can be initiated slowly. And however, in this there is a dose dependent response, and there is a reduction in sleep interface. The speed of onset of relief has been said. Patients do complain of dizziness, somnolence, and peripheral edema. A lot of them come back with saying that they have edema in their ankles, which sometimes can be a little difficult because then they put on weight, they are again unable to move about. However, this should not be abruptly discontinued because sometimes it could land up with cerebral edema and encephalopathy. A study which compared duloxetine with pregabalin in diabetic peripheral neuropathy showed that both of them are as good as each other in comparison when they were studied. Besides that is the opioids. Now, opioids are usually used as a second line. They are centrally acting and they bind the mu opioid receptors. There is a significant pain relief and it is very effective in diabetic peripheral neuropathy at a dose of about 200 mg per day. But there are adverse effects of nausea, constipation, headache and somnolence. However, these patients, there's another opioid also which is oxycodone, which also has been used in patients with similar effects. The use of opioids in DPN is, however, a little controversial. These trials which were used, the sample size was small. There is no basic establishment of the risk and benefit ratio. The long term, the patient lands up being dependent on opioid and there is abuse of the drug. Besides this, constipation, itching, these are the common side effects. Instead of taking opioids, we can usually evaluate whether the person has earlier taken it, because a lot of times when the patient presents and comes with those very severe pain, sometimes he might be also trying to mimic in such a way that he wants the drug to be given to him, but actually they do not give a very clear history. This also, the worrying side effect that is there is the changes in the immunological function and the suppression of the pituitary axis. So it should ideally not be started unless there is nothing else that you can do to relieve the pain. And you should evaluate the person to see whether they have been taking it before and whether they understand that you are giving it to them for a short time, for a just to relieve the pain, and then it has to be stopped. The local treatment which can be used is capsaicin. It is an alkaloid which is derived from red chili peppers. It is effective as a local applicant. The cream which was available for some time is not very effective, but the 8% patch which is there has been studied extensively and found to be helpful. However, the epidermal denervation with subsequent nerve regeneration occurs in diabetic peripheral neuropathy. So this should make us use this with caution. So now gabapentin, nortriptyline, or a combination of both. This was a double-blind trial which showed about 56 patients tried this in a 1:1 ratio, and it was found that it was pretty well tolerated. The gabapentin as well as the nortriptyline and the combination was also pretty well tolerated. However, the most common adverse effect is the dry mouth. Now the other medications, because there is constantly a relentless challenge to to find what is the medication that can relieve the pain. Lidocaine has also been approved for this use, and it is a sodium channel blockage which dampens the peripheral nociceptor sensitization, and thereby ultimately the CNS hyperexcitability is reduced. The side effects are the skin rash and the edema which occurs. Then there is an oral analog called mexiletidine also which is used, but it is not yet used very safely. We need to do an ECG to monitor its use because of it could cause cardiac arrhythmias, because we don't want to give something to reduce the pain and the patient has to have a treatment for a cardiac arrhythmia. So what are the pharmacological choices that we have? First would be pregabalin, then would be the amitriptyline or the duloxetine, and the other such medications. Anti-epileptic medications also are used. The Velflaxacin could be added on, the lidocaine patch. If still it doesn't work, doesn't relieve, then we also have decipramine, imipramine, which used to be used a long time ago. I don't think I have seen it used too much. Fluoxetine sometimes is used. Besides that, we also have vitamins available, alpha lipoic acid and other vitamins, B12 and other vitamins are also used. Oxycarbazepine, botulinum toxin, that's Botox, is also given in low strength, but it doesn't really improve the quality of life. So what are the other treatments? Like alpha lipoic acid, this is a cofactor for many of the enzyme complexes. So therefore, which include the aerobic metabolism, and it has been shown to have some effect in the patients. Another new thing which is under evaluation is medical marijuana, because these days that seems to be the treatment for anything and everything. It is being evaluated. CBT, as they call it, is also being evaluated for all these functions. But the studies are still going on, and the sample size is not too big so as to show that it is promising. There are other lifestyle non-pharmacological therapies, because the patient doesn't stop. If we are not able to provide a solution to the pain, they keep looking for somebody else. And a lot of times, some helpful neighbor, friend, relative, spouse, sibling will give them some sort of help. Of course, that is whether it actually helps them or not to relieve the pain, because I've had very interesting things. Once there was a patient who was told by somebody else that to take a papad, roast it, take the hot papad, wrap it around his foot along with the clot. I don't know whether it relieved his pain, but it caused an ulcer for sure, because he did not feel the sensation, but he landed up with a foot ulcer, and that caused even a amputation of his foot. So, but of course, the most important thing is lifestyle modifications which need to be done. If there is some physiotherapy which can be done, occupational therapy, something which can be done, the podiatric care, because a lot of times we we see earlier that the care for the feet, the toes, everything needs to be done properly. They should probably wear specialized footwear. They could be also cognitive behavioral therapy, biofeedback mechanism, other complementary therapies like acupuncture have been shown to show some effect. But these are things which still need to be studied for them to be used in the long run. There are other devices like these transcutaneous electrical stimulation. They are also used, but it is a little it's very dicey to use some of them, because these people might land up with some foot ulcer, like I said. There are other therapies. People will give people will advise some laser therapy, some infrared light, all sorts of things, anodyne therapy, or ozone, many other therapies are advised. Besides this, sometimes when the pain is too much, even anesthesia, regional anesthesia could be given for these patients. If it's very severe, then spinal cord neurostimulation is still in the experimental stage. The peripheral nerve compression also. So that is for managing the complications and restoring the function. Now, what about the nerve growth? We still do not have anything really which can help in the nerve growth. But there are some chemicals which are being analyzed, like the SB509. It's a formulation of a zinc finger DNA binding protein, which is being assessed. Exercise is something which has been shown to have some benefit in peripheral neuropathy. The patient should be advised to exercise regularly and not just do some cardio exercise, but also they should move their feet, because a lot of times we do not even examine the feet, we don't discuss the foot, but we must tell the patients that they should look after their feet on a regular basis. Every evening they should check the foot, whether there is any cut, any callus, any red area, any blue areas, and definitely after that they can wash and apply some cream, and they should exercise the toes. There should be a schedule which tells them how they should can exercise their toes. Maybe it could be done by a physiotherapist, or even we can just tell them briefly. Exercise means a lot of things to a lot of people, but usually exercise is something which most of our patients try to avoid. Besides that, there are these other studies which are going on, which epidermal skin innervations which are done, and they made them do some supervised aerobic exercise, and they found that there's a decrease in the pain interference. The ADAPT studies which showed the activity for diabetic polyneuropathy, this was, the primary goal was to determine the novel approach to increasing the home activity and reducing the sedentary time in the patients. And this showed that over the 5 years that this was able to improve the neuropathy. Besides this, there are some ongoing basic research, basic science studies which are going on, which show that various compounds are being tried to define that the role of neurotrophins in diabetic neuropathy, to design better treatments. There are other studies which are being, the Viromed, the Vertex study, these are all ongoing. So finally we come to the conclusion. So painful diabetic neuropathy is something which we see day in and day out. It's very common. Most of our patients at some point of time would have complaints of it. And it is associated with a significant impairment of the quality of life of the patients with diabetes. And they are unable to do their daily functions. They are unable to work. Like I said, because if they're spending the time, they cannot sleep because of the pain, they're not able to work the next day. And though it has a high burden, but still it is largely undiagnosed and undertreated. Most of the time, the patients don't even know that they are supposed to report these complaints. A lot of time they, ignore it. They land up with a foot complication or even a small wound which doesn't heal. The treatment to repair the nerves has yet to be found and translated into clinical therapy. However, various symptomatic therapies are proposed to manage the neuropathic pain. Few have been effective, and future research is ongoing to establish what would be the most efficacious drug combinations. Like I said, this is the way a lot of times patients do present, with various shooting pain, burning pain, all sorts of things. With this, I would end my presentation. Any questions?